Philippa is going to be talking about Minds Together for family, friends and carers supporting someone who has attempted suicide.
Well, hi everyone. Thank you so much for having me here at this forum today. I really appreciate being invited, and I've really been enjoying learning along with the rest of you. Excuse me, my voice is a bit croaky today. My name's Philippa Ditton-Phare, and I'm a research lead at Everymind, and today I'm going to be presenting some findings of a qualitative study that we did as part of a broader mixed methods research looking at Minds Together, which is an online program for carers supporting someone experiencing suicidal distress or following a suicide attempt. And this program is a new program that was developed from the original pilot, which was for carers supporting someone following a suicide attempt. But firstly, I'd really like to acknowledge the traditional owners of the country that I'm on today, the Maru Ora Dial people, as we learnt from the Welcome to Country this morning, as well as the Bidjigal people of the Eora Nation. I recognise and celebrate the continuing connection to land, waters and culture, and I pay my respects to elders past and present, and extend my respect to any Aboriginal and Torres Strait Islanders here with us today or online. I'd also like to acknowledge people with lived and living experience of mental health concerns, alcohol and other drug concerns, and suicidal distress, and those who care for them. Their experiences are essential to improving the way services are designed and delivered. So a little bit about the organisation I work for. Everymind is an organisation dedicated to the prevention of mental ill health and suicide. And we're based in Newcastle, but we work nationally across Australia. And we've been delivering programs for over 30 years. Everymind has 5 priority program areas, and one of these program areas is our Family, Friends and Carer program. And more specifically, Minds Together, which is a suite of programs for family, friends and carers supporting someone experiencing mental ill health or suicidal distress. And the work I'm about to discuss, as I mentioned, is on a specific program that we studied for carers supporting someone following a suicide attempt. So through our research, we've found that people often rely heavily on family, friends and carers for support following a suicide attempt. And the carers we've spoken to report that this informal role can be really deeply meaningful and rewarding, and they get a lot out of the role. But they've also talked to us a lot about the challenges they face, including navigating services and managing their own distress and supporting someone through complex aftercare processes, often without guidance. So to help address this gap, Everymind developed this Minds Together program to provide practical strategies and emotional support and validation for the critical role they play in supporting someone following a suicide attempt. The program is free and online and self-paced, so people can engage with it in their own time and at their own pace, and it includes interactive activities, multimedia content like short videos and podcasts, and real stories from people who have supported someone experiencing suicidal distress or following a suicide attempt. In addition to the modules, there's also access to a moderated online social forum where people can connect with others in similar situations. And to ensure the program continues to meet the needs of these carers, we undertook a research study that included in-depth interviews with participants to explore their experiences and identify opportunities for improvement. So today I'll share what we learned from those interviews and how those insights gathered informed improvements we made to the current program. So as I mentioned, these interviews were carried out as part of a larger research program. I think we had about 75 participants do surveys, and we had 7 participants who then engaged in some qualitative interviews with us. And this happened May to August 2022, and we analysed the data using Brown and Clark's 6-step thematic analysis. Transcripts were read and annotated to develop initial codes, and we then uploaded these into NVivo, and we had them independently coded by 2 researchers. The coding differences were then resolved through discussion, and themes were developed to reflect both individual perspectives and broader patterns across the data. So the interviews gave us valuable insights in 2 key areas. Firstly, the carer's broader experience as a support person after a suicide attempt, but also their specific feedback about the program. So starting with what participants shared about their experience as a carer or support person, many described how difficult it was to navigate systems, especially the mental health system. And this included finding and securing appointments with professionals such as psychiatrists or psychologists. They also spoke about the ongoing need to advocate for the person they support and the frustration of not being kept informed or included in communication when they were navigating services. They also highlighted day-to-day challenges such as managing logistics and trying to take care of their own well-being and coping with highly stressful and uncertain times alongside the person they support. And a strong theme that came through was the need for accessible and relevant information. One participant described this period as a particularly dark time and reflected feeling lonely and desperate for information, even while receiving professional support. So their experience really highlights to us the importance of timely and accessible information for family, friends and carers following a suicide attempt. Participants were also asked about how they felt about the term carer and whether they found it appropriate or preferred another term. There wasn't a real clear trend in the responses, with a variety of views expressed. Some felt it accurately described the additional responsibilities they'd taken on. Others expressed discomfort with the label, feeling it could be pathologising or not reflect how they saw their role. Most tended to identify through their relationship, which I think is common, particularly early in someone's caring journey, such as a parent or partner or friend, sibling. A few suggested support person as an example of a preferred alternative. In addition to their experiences supporting someone following a suicide attempt, interview feedback highlighted a range of key considerations about the program, which fell into 3 main categories: access, program impact and content. So feedback relating to the program content was positive, with most of the discussion revolving around the authenticity of the stories that they heard from real carers in the videos. Well-structured content and relatability of content. So those asked if they would recommend the program to others said they would. And in terms of the program impact, 5 of the 7 interviewees felt that the program provided them with a sense of shared experience, this shared experience was mostly established through the videos of the carers that were providing content within the program. And one participant described it as really empowering and inspiring to see others who'd made it through similar situations. Another noted that hearing people's stories helped reduce feelings of isolation, stating it had a calming effect and an empowering effect. Additionally, participants noted that the program provided a sense of progress and improved their ability to prioritise and gave them hope. In the larger research study, which was a pilot randomised controlled trial, staggered access to the program modules was a deliberate design choice to support the program evaluation. But participants who took part in these interviews expressed that this staggered access was a limitation for them. And I really want to acknowledge that limitation in randomised controlled trials. It can be really difficult. And in addition to that, access to the program during the trial was limited to 8 weeks. So many felt that having access to the program up front would have better suited their needs. and particularly during times of crisis or when the person they supported was in hospital and they actually had time to look at the program. One participant shared that by the time their daughter was home from hospital, they were busy with appointments and wished they could have accessed the whole program at a time that suited them to better suit their schedule. I'm really sorry about my voice, guys. Struggling with it. So feedback and insights gathered from pre and post program surveys, along with the more detailed feedback we got from the qualitative surveys, qualitative interviews, really helped us to inform updates we've made to the Minds Together program since then. So we've made 3 key changes to improve it, make it more useful and beneficial for family, friends and carers, and these include a new module that we've added for family, friends and carers to support someone experiencing suicidal distress. So it's really important to ensure that we added that to not only look at the diverse experiences of family, friends and carers, but also help to provide support prior to an attempt, not just following an attempt. So this has led to the renaming of the program now to include both suicidal distress and suicidal attempt in the title. We also removed staggered access to the modules, so participants now receive full access to the entire program from the beginning, allowing them to engage at the content in whichever order they want at their own time and pace. And there's also no limit on time access. So this was a key improvement in response to their need for that timely information. And we also streamlined our evaluation process by reducing the number of surveys used and embedding quality improvement evaluation questions within the program, so we don't have to send them off to REDCap or anything, and they can just fill in a few short questions after each module if they wish. So as well as these 3 key changes, user experience and navigation were reviewed again in consultation with a family and friends reference group, which contained carers with lived and living experience. And based on their feedback, several other enhancements were made, including the addition of a navigation sidebar, some progress tracking, and more inclusive and culturally appropriate language and imagery, and the increased use of interactive elements to support engagement. So together, these changes, I guess, reflect the commitment to improve the program and be responsive and inclusive and use lived experience advice to ensure the program continues to meet the needs for family, friends and carers, supporting someone experiencing suicidal distress or following a suicide attempt. So we are currently funded to embed this program in New South Wales and ACT, funded by the Ministry of Health and the ACT Health Directorate, into aftercare and other services. We're currently running around the states and territories, visiting every single aftercare service that exists in those 2 states. And the program can be accessed through these links. So these are specific landing pages for each state. If you or any family, friends and carers that you know in New South Wales or ACT might need access to this program at the right time and right place when they need it, please let them know that it's available. I really thank you for your time and listening today. I'm sorry I've been struggling with my voice, getting over a head cold. I really appreciate the opportunity to be here, and if you have any questions, I'm happy to answer them now or over the lunch break, no problem at all. Thank you.
Thanks so much, Philippa. Any questions? Beck.
Thanks, Philippa. What a great presentation and amazing program. I guess I'm just curious about the levels of carer distress of people coming into and finishing the program, and whether you have kind of practices to be able to refer particularly distressed carers on for further support. I guess I'm just wondering, how is that built in, or if it is built in?
Yeah, it is built in. So the program's designed as a prevention early intervention level program to help carers who are ready to receive the information about improving their capability for caring in this context, looking after themselves, etc. But anyone in extreme distress is going to need more support than just reading stuff on an online program. So we talk about that at the beginning of the program, like they've always got access to additional supports within the program at all times, but we specifically let carers know that, you know, if you need help right now, please call Carer Gateway or, you know, Lifeline, you know, all the numbers, and that this program's not designed to be acute support for mental health concerns or severe distress right now. You really need time and headspace to be able to take on the information and be ready. Yeah. So there's an element of readiness there. And we have more access to supports at the end of every module, but there's a Need Help Now button right at the top at all times. Yeah.
Thank you. Any other questions? Lucas.
Thank you. That was great. What struck me a bit, like thinking about across presentations, is sort of temporality as an issue, and sort of what stumbled me was like this, okay, you roll it out staggered because that's how you roll a program, but then they want it all at once. Some feedback is they want it all at once. Do you have any data around the use, whether it gets sort of reused in times of crisis or whether it only gets used, like people see it, don't use it, and then when they need it, they use it then? Do you have any data around that?
That's a really great question, and I'm hoping to be able to answer more of that now that we've got our evaluation more open, and over a longer time period, we're now able to look at by module and by page exactly how people are accessing the program and whether they're doing something else first and coming back to it. In the original trial, they could only do it in order. So they couldn't, it's not like they could go back to something go forward to something and start at section 3, for example. They had to start at section 1 and get all the way through that. They had 1 week with one section, and even if they were ready to start section 2, that wouldn't open for another 7 days. So it was really staggered for them, and I think that would have been, on reflection, it would have been extremely frustrating. And that trial was set up before my time at Everymind. But I would just like to say that I think in the future, I want to take those things into consideration in terms of making sure that the experience for carers is the first priority, and then considering how we can couch research and evaluation around that rather than trying to push people into particular study designs because that's what we want. So
Thanks, Philippa. Please join me in thanking Philippa.
thank you.